Okay, hello everybody, and today we'll be covering the cranial nerves. Just to, start off the lecture, the cranial nerves are incredibly important and you need to memorize them forward, backwards, their functions, their entrance, their exits. It will be tested again and again and again, and you will also have to be using them in a clinical scenario. So, cranial nerves 1, 2, and 8. The olfactory, optic, and the vestibular trochlear are all sensory nerves. And cranial nerves 3, 4, 6, 11, and 12. This is the ocular motor, the trochlear, abducens, accessory, and hypoglossal nerves are all motor. The rest of them are mixed fibers. So the motor nuclei are located medially in the brainstem, and the sensory are lateral. These are generalizations, of course, but just important to know as a reference. The general visceral motor nuclei are the parasympathetic nuclei, and the sensory somatic and visceral afferent nuclei are both sensory and motor neurons, so they are the mixed neurons. And those are a part of the peripheral nervous system. So look here. Medial, somatic, those are the motor, parasympathetic, these are lateral, brachiomotor, that means they go down and innervate the arm. These are more of the somatic. Here you go. Look how nice and lateral that is. Taste and baroreceptors. Baroreceptors are the receptors that respond and sense differences in pressure. And this is particularly important in large vessels such as the aorta. And special senses are like pain and temperature. And so the nerve roots, cranial nerves 1 through 3, come from the interpendicular fossa. Here you go. This is the sagittal sulcus of the brain, and cranial nerve number 4 comes from the dorsum of the pons. This is the pons right here. The 5th cranial nerve, the trigeminal nerve, that is from the anterior aspects of the pond. The cranial nerve number 6 come from the pons and medulla. This is the pons. Right here's the medulla. 7 and 8 come from the cerebello-pontine angle. So here is 7. Here is 8. So there's this tiny little angle here. We'll go over that in further lectures. Cranial nerve 9. So 4 to 5 of its rootlets. Where am I pointing this? Cranial nerve number 8 right here. Cranial nerve number 9. So 4 to 5 rootlets are in the cranial post-olivary. So the post-olivary is actually back here. This part of the brainstem is actually covering it up. And for cranial nerve 10 of the filaments are in the post-olivary sulcus. And cranial nerve 11, the series of rootlets emerge from the post-olivary sulcus and from the spinal cord, as you can see here. And cranial nerve number 12 is from the pre-olivary sulcus. We'll go over those structures more in the lecture about the brainstem, so don't worry about it now. But just know in general that the upper cranial nerves are located superior to the brainstem, so it makes sense, just go down the brainstem. Okay, so cranial nerve number 1 is the olfactory nerve, and the filia olfactoria are these tiny little filaments that pierce the olfactory epithelium into the nasal cavity, and those innervate the olfactory mucous membrane and enters the cribriform plate. And they work because when you inhale, the air conveys scent particles And then when you take a breath, it goes through the turbinates and then reach the filia olfactoria and bind, and then from there it goes into the olfactory bulb and then goes through the olfactory tract for the brain to process the smells. Us humans, though our noses are not quite as good as canines, we can identify many smells, and it is thought that smells are particularly linked to memory because it is so close to the hippocampus region right here. See, as it goes through right there. So it kind of evokes emotion as well because the emotional cortex is right there. So whenever you smell something familiar like cookies and you have it associated with a certain memory, like your grandmother always makes cookies, whenever you go past like a pastry shop and you smell chocolate chip cookies, it's going to stimulate these centers. So lesions in the olfactory nerve or around the olfactory nerve that compresses this particular area will lead to hyposmia and anosmia. Hyposmia is the reduced amount of I don't want to say smelling because it's not that, but there is a reduced amount of sensory information going back into the brain because lesions onto the olfactory tract will not prevent the scent particles from being able to bind to the filia olfactoria, but it will interfere with the process of us, our brain processing these smells and then making the connections so we can recognize smells. Severe damage or large lesions will create anosmia, which means just a lack of smell. So cranial nerve number 2 is the optic nerve and is made out of the axons of the ganglionic layer of the retina, and it merges from the back of the eyeball through the superior optic chasm in the superior optic fissure, and then enters the brain through the optic canal, and then they desiccate in the tuberculum sella in the optic groove, and they cross and then they go to both sides of the brain, and then that's where we integrate it in the occipital the occipital lobe. That's where we integrate the information that we receive. So they, like I said, unite with the optic nerve and the optic chiasm, and then let's go back. I guess I didn't write it down. A stroke, or depending where it is, will only affect one part of the visual field. It's particularly bad if a stroke happens into this region because you won't be able to either integrate the images that you see, or you will be blind in both eyes. So the ocular motor nerve is cranial nerve number 3, the trochlear nerve is cranial nerve number 4, and the abducens is the cranial nerve number 6. And here is a cadaver image. This is trochlear right here. This is the frontal nerve. This is a division of a facial nerve, and here are all the muscles. So the ocular motor nerve will innervate the pupils and the lenses, the upper eyelids, and just know that they innervate the muscles that allow tracking and gaze fixation. So this allows you to focus on moving images and images that are far away. The ocular motor nuclei innervate the somatic efferent nucleus, which will supply the ocular muscles. Edinger-Westphal nucleus is where the preganglionic parasympathetic fibers come from. So those are just fancy words of just locations where the fibers kind of gather. Okay, so The trochlear cranial nerve number 4 supplies the oblique muscles of the eye, and that will allow the eye movements of intorsion, extorsion, raising, and lowering. If a stroke occurs and interferes with the trochlear nerve, eye movement is affected. So here are the eye movements. Adduction will allow you to focus on images that are very close to your face. These muscles also help you, see cross-eyed. Supraduction is looking up. Infraduction is looking down. Abduction, we can't move both of our eyes in abduction, so it's one eye will abduct and one eye will adduct. So abduction is you looking at the corner of your eye. And these are the important ones because these are the movements that integrate all the muscles. So intorsion allows you to raise your eye and look medially. So when you roll your eyes, right? And extratorsion is when you raise your eye and then look downwards, kind of like that, right? So this is, I like to think of this as intertorsion is when you roll your eyes inwards. Extratorsion is rolling your eyes outwards. So, of course, these cannot work concurrently. One eye will be will go through intertorsion. One eye will go through extorsion. Okay, here's the most important nerve for you to study because there are 3 parts of it. That's why it's called the trigeminal nerve. So this is the 5th cranial nerve, and the main sensory part of it lies in the posterior pons, lateral to the motor nucleus. The spinal nucleus will continue superiorly with the main sensory nucleus, and it will extend inferiorly through the medulla down to C2. So it has the superior and inferior division. The mesencephalic nucleus will extend down to the pons, and then the motor neuron nucleus is all in the pons. Okay, so the sensory aspect of the trigeminal nerve are the fibers that convey the sensations of touch and pressure, and those will terminate in the main sensory nucleus. The fibers that convey pain and temperature will end in the spinal nucleus. So this one they will terminate further back past the motor nucleus and more towards the spinal region. Proprioceptive impulses from the facial, ocular, and muscles of mastication will bypass the sensory semilunar ganglion, and they originate in the mesencephalic nucleus. The axons of the main sensory and spinal nucleon and cranial process or central processes of the neurons of the mesencephalic nucleus will cross the median plane and ascend as the trigeminal lemniscus and terminate in the ventral posteromedial nucleus of the thalamus. So what does that all mean, right? The motor root will travel deep to the trigeminal ganglion, and it will go through the skull and intracranial course, leave the anterior pons in the posterior cranial fossa, and it will rest on the surface of the petrous bone. And from there, it will go through the Meckel's cave, and the 3 divisions will leave the cranium through the foramina. So it'll leave through the supraorbital foramina, or the foraminal notch, depending on the person. And then there is the infraorbital foramen, and then the mental foramen. So the semilunar ganglion is equivalent to the dorsal sensory ganglion in the spinal nerves, and they lie in an invaginated pocket of the dura in the middle cranial fossa, and it lies near the apex of the petrous bone. So that is a good surgical landmark, the petrous bone, right? So the motor root and the greater protrossal nerve will pass deep to the ganglion, and medially it lies. It will lie next to the internal carotid artery and the cavernous sinus. So here it is. It's very close to the optic nerves, you can see. And here it goes, branching out into, like this is the orbital cavity. So the ophthalmic division will branch off into the lacrimal, frontal, and the nasal ciliary. So the lacrimal will innervate the lacrimal glands, allowing tears to form and lubricate the eye. The frontal will be the largest branch, and that will divide into the supraorbital and supratrochlear nerve. And the nasal ciliary has two divisions, the anterior and posterior ethmoid nerve, the long ciliary and infratrochlear branch, the ramus communicans, and that will go to the ciliary ganglion. And the ciliary ganglion innervates the sphincter pupillae and the ciliary muscles. So those are fine nerves and muscles that allow the eye to focus on objects. So those will enter the short ciliary nerve and carry the sensation from the cornea, ciliary body, and iris. So part of the part of the ciliary ganglion and muscle is that it will perform the corneal reflex. So when anything touches your eye, whether it be dust or grit or something, it will trigger the reflex for you to blink very hard to get all of the dust and whatnot out of your eye, and it will cause the lacrimal nerve to fire and for tears to well up in your eyes. This is an important clinical feature because if you perform a corneal reflex on somebody and they do not respond, there is going to be a problem in the ophthalmic division of the trigeminal nerve, and then you would have to see if there a stroke has happened or some kind of trauma. So the maxillary division will come from the pterygo-palatine fossa, so more towards the middle part of the brain. And it has two nerves. It will be the zygomatico-temporal and zygomatico-facial nerve, and then that will branch into the infraorbital nerve, then the posterior superior alveolar branches right here. And the branches of the pterygo-palatine ganglion would be the greater and lesser palatine nerves. So that would be within the palate, right? So like imagine this person's mouth being open, then you can see the foramina. The pharyngeal branch that would go actually down to the throat, and then the nasopalatine, here you go, into the nose, and the posterior superior lateral nasal nerve, so that would like actually innervate the outside of the nerve. And so this will convey sensory information from the face and from the nose and from the teeth and mouth area. So if you get punched in the face, the nerves that would be affected would be like all of these, right? The infraorbital nerve, alveolar nerve, and the nasal nerves. So the mandibular division is the largest division, and this is the only one that conveys the motor fibers. So everything else just relays sensory information. This one has both. This one has the sensory branches of the buccal, the inferior alveolar, the lingual, that means tongue, and the auriculotemporal and spinous nerves. So all in this division right here. So the motor branches to the muscles of mastication, and those would be the deep temporal, the medial, and the lateral pterygoid. And these will allow you to open and close the jaw and to actually move it side by side. So the motor branch will go to the mylohyoid anterior belly of the digastric. That is a muscle in the throat. We will cover that later. The tensor tympani would be back here, and the tensor veli palatine. So all these muscles allow you to chew. So trigeminal nerve neuralgia is intense facial pain. It's usually unilateral, and it can be caused by tumors or strokes and cause compression. So when a patient comes in complaining of unilateral intense facial pain that is triggered by very, very light pressure or even by just air blowing on them, you can be suspecting that they have some nerve neuralgia, and in order to do like a nerve block or know exactly like where the damage is, you can see where the pain is the greatest and determine which branch of the trigeminal is being affected. So up here would be the, of course, the first branch, the ocular branch. Then down here would be the maxillary, and then all the way down here would be the mandibular branch. Okay, so cranial nerve 7 is the facial nerve, and the nuclei is the main motor nucleus in the lower pons. A part of the nerve will supply the upper face, and it receives the fibers from both cortices. The part that supplies the lower face receives fibers from the opposite hemisphere, so the fibers will desiccate, which means they will cross within the hemispheres. The parasympathetic nuclei are the superior salivary and lacrimal. These will supply the glands in your mouth and in your eyes. The nucleus of the tractus solitarius are the sensory nuclei that lies close to the motor nucleus. And these are the branches. This is the temporal branch, and those will innervate the frontalis, orbicularis oculi, and the corrugator supercilii. And the zygomatic branch will innervate the orbiculus oculi. The buccal will innervate the orbiculus oculi again, and the buccinator and the zygomaticus. So these are the muscles that help you smile. The marginal mandibular branch will innervate the mentalis. So this will innervate like your jawbone. And the cervical branch will innervate the platysma, a very thin muscle in the neck that we will cover in a future lecture. So as you can see here, there are lots and lots of nerves innervating the orbiculus oculi. Why is that, right? Because it is quite an energy rich and coordinated muscle. So you need to be able to coordinate opening your eyes at the same time and closing them at the same time. That's the more important part, like closing them so you can protect your eyes. That's part of the reflex arc, right? And it is a very vascular area as well, so vessels will be following these nerves because the eye just requires a lot of energy. We use our eyes for a lot of for everything, really. Humans are visual creatures. So this one's a special branch because the cranial nerve 7 derives from the second pharyngeal arch in human development, and this does not supply the skin. So this will only be made of the motor roots that will curve around the abducent nucleus and the sensory root, and those have the parasympathetic fibers. Both roots will emerge in the cerebellopontine angle, and they will pass into the internal acoustic medius, and then the facial canals. So the canal behind the medial wall of the tympanic cavity nerve will expand to form the sensory genicate ganglion. So the branches of the canal of cranial nerve 7 will go into the stapedius muscle, which is in your ear. And the greater petrosal nerve will innervate the lacrimal gland. And the chorda tympani originates from the taste buds, and then they run through the middle ear and carry the taste messages to the brain. There are a couple branches, the posterior auricular that will innervate the ear, the posterior digastric belly, and the stylohyoid, those are neck muscles. There are the temporal, zygomatic, buccal, marginal, mandibular, and cervical branch plexuses. And that just means that they're all gathered, in a um, complicated kind of network. So facial nerve lesions, that means that the abducens and the facial nerves aren't working. This would indicate that this would be a Pons lesion. A vestibular, cochlear, and facial lesion would be an internal acoustic meatus lesion if those two are affected. Hyperacusis lesion is a lesion in the nerve to the stapedis, so that will impair your ability to hear. And loss of taste over the anterior 2/3 of the tongue is a chorda tympani injury. Bell's palsy would be a paralysis on a half of a face. It would be this is not a disease; it's a symptom, really. It's a hallmark of a facial nerve lesion, but it can be caused by several other different things. So usually it's a damage in the acoustic meatus, caused by ear infections. Operations could damage it, and parotid gland tumor can cause it, and a laceration that will cause or trauma to this particular nerve. So cranial nerve number 8, vestibular cochlear, is purely sensory. It will go into the internal acoustic meatus, and there is no exit. There's 2 branches. The cochlear nerve is the branch that deals with hearing, and the vestibular nerve will deal with information on balance and spatial orientation. So, if somebody experiences problems like vertigo and dizziness, this is generally not a vestibular cochlear problem. That is usually a problem with the stones inside of the internal ear, and that will be covered far in the future in your like neuro lectures. But generally, damages to this nerve is doesn't really cause like vertigo and dizziness, So cranial nerve number 5 is the glossopharyngeal nerve, and that will move the throat and the palate and the tonsils. The main motor nucleus is in the medulla, and the parasympathetic inferior salivary nucleus. The sensory nucleus of the tractus solitarius are the taste fibers and impulses from the carotid sinus. Afferent information that concerns common sensation will enter the brainstem through the superior ganglion of cranial nerve 9, but they will end into the spinal nucleus of the trigeminal nerve. So these two are quite close to each other. As you can see here, it goes down the neck and then back. So 4 to 5 rootlets will exit post olivary sulcus and enter through the jugular foramen. And then it will descend the neck with the internal carotid artery and the internal jugular vein to the stylopharyngeus muscle. The tympanic plexus will supply the mucosa of the tympanic cavity, eustachian tube, and the tympanic membrane. So all kinds of, it goes from mouth and ear and then down the neck. It's also known as Herring's nerve. Okay, so the vagus nerve is quite an involved nerve. Cranial nerve number 10 will innervate the stomach, the pharynx, the soft palate, and the motor nucleus lies in the medulla, made by the nucleus ambiguus. The parasympathetic dorsal nucleus of the vagus nerve innervates the lungs, the heart, and the GI tract. The gustatory fibers will enter the inferior ganglion, and the primary afferents from the viscera will enter as well. So the afferent fibers will enter the spinal nucleus of the cranial nerve number 5, and the rootlets arise from the post-olivary sulcus, and they will leave the skull through the jugular foramen. So the superior sensory ganglion of the vagus nerve will be it will have like the auricular branch, which will innervate the concha, the tympanic membrane, and then the meningeal branch will innervate the dura mater. And the inferior ganglion will innervate the taste buds, the chemoreceptors, and the baroreceptors in the aorta. It will also innervate the heart, the respiratory muscles, the GI tract, and the urinary tracts. A lesion will cause dysphagia ipsilateral to the lesion. So when you ask the patient to open their mouth and say ah, the palate will raise, right? And in a patient with a lesion on cranial nerve 10, if they say ah, and let's say the right side is paralyzed and it doesn't rise, the lesion would be on the right side of the vagus nerve. Like the vagus nerve, there's two branches, that innervate the left and the right sides of the palate. The right side, if paralyzed, would be affected by the right-sided lesion. That's what ipsilateral means. The superior laryngeal nerve damage will cause anesthesia to the upper larynx, which will cause voice weakness. And the recurrent laryngeal nerve is a sensory innervation to the larynx, cardiac branches to the trachea, esophagus, and the cricoarytenoid muscles. And a damage to that nerve will cause hoarseness, dysphonia, aphonia, stridor, tachycardia, or arrhythmia. So dysphonia means difficulty speaking. Aphonia means you can't speak at all. Stridor is when there is when people are speaking unnaturally forced. And the important clinical feature of the recurrent laryngeal nerve is that it's not symmetric, unlike all the other nerves. So there is one branch that is longer than the other, and that would be the branch that innervate down to the heart. Okay, cranial nerve number 11 is the accessory nerve, and that will raise the sternocleidomastoid and the trapezius muscles, allowing you to raise your shoulder. And it enters through the foramen magnum and leaves through the jugular foramen. An injury to this nerve will cause weakness in elevating the shoulder and rotating the neck. The hypoglossal nerve is cranial nerve number 12, and this is a motor nucleus, and it gets both of its corticonuclear fibers from both hemispheres. It innervates the genioglossus and gets fibers from the opposite hemisphere, so somewhere it will desiccate. It emerges rootlets between the pyramid and the olive, down in the medulla, and they leave through the hypoglossal canal in the skull, and it will travel down the neck between the internal carotid artery and the internal venous jugular. So it is an important triangle to know. This would be the carotid triangle. And if you get stabbed there, or there would be trauma in that area, these structures would be damaged. So the hypoglossal would innervate the tongue, the styloglossus, hypoglossus, and the genioglossus. And it also innervates the superior root of the ansa cervicalis. This is the clinical features. Damage to this nerve will cause a deviated tongue and mild weakness, as in you would ask your patient to push against your finger through their cheek. So you would rest your finger on their cheek and ask them to push your fingers away. They would not be able to push very strongly. In severe weakness, they wouldn't be able to push or wiggle their tongue from side to side at all. So the lower tongue deviates ipsilateral to the lesion, the muscles atrophy, and there is some fasciculation. So there would be twitching, some constant contraction of the muscles involved. Okay, that was quite a long lecture. Thank you for paying attention, and that's it for now. Good luck studying.